As part of our commitment to reshape the future of healthcare, the University of Arizona Health Sciences created the Comprehensive Pain and Addiction Center. It is the nucleus for treatment, research, trials, drug discovery, technology, education, and legislation. The center, spearheaded by Dr. Todd Vander Aar, fosters interdisciplinary collaborations to tackle issues related to chronic pain and addiction by bridging the gap between clinical medicine and research.
For some people, pain is pain. Well, that's not exactly true. There are so many different types of pain. There's acute pain and there's chronic pain. For example, if someone gets a surgery, yeah, of course they're going to be in pain or some degree of discomfort, and that's expected. That's called acute pain. And different stimulus or different insults will have different length of time that we expect someone to be in acute pain. However, if for whatever reason that pain persists beyond what's expected, then that acute pain transitions into chronic pain.
Over the years, of course, we've started to realize that everybody's pain is different. So it's interesting in the fact that pain is activated by the same sort of pain fibers that are very similar in all of us. But how we sort of manipulate that within the nervous system, how that changes is different in everybody. And what we've realized is that the brain really plays a huge role in either masking the pain, trying to inhibit it, or trying to enhance it.
To be realistic, if the medicine we're practicing tomorrow is the same as the medicine we're practicing yesterday, then I don't see us advancing 10 years from now.
We need to deal with pain on a level where it's not just trying to only inhibit the pain fibers. I mean, that's one thing, and that's what sort of the opiates do. But we need to start thinking more broadly about what is causing this ongoing chronic pain. And of course, sometimes it's going to be pathology in cases of like arthritis, in which we're trying to help with the loss or damage of the joint. But in many cases, the pain can be what we call catastrophized by the anxiety and depression. And that's not something we really have been set up to do. We haven't really been at a level where we want to say that we need to help you with the fact that your anxiety is probably also creating more pain. And it's creating a system where it's sort of hyperactivating your pain fibers.
So the management for a chronic pain patient can vary from something as simple as lifestyle modification to maybe a little bit of physical therapy, acupuncture. We certainly like to explore these non-pharmacological methods first because, in all honesty, they come with very minimal side effects. And I don't want to put opioids in the evil category. They still have a role and a very important role to play, but for most people, it's not necessarily the first line of treatment. There are other pharmacological agents that we can explore first, that we can utilize prior to thinking about opioids.
We usually feel that the patient will do better if you just understand that, look, we're going to try to get rid of 70% of your pain, or even lucky if 80%, but we're also going to help you with the fact that you might be able to sort of sleep or come up with some different methods to sort of help you with your life and how you sort of approach the quality of life. And so that's some of the things that we're planning, obviously, in this new center.